Hello, everyone. My name is Catherine Ferrier. I'm a physician in Montreal, Canada. Bonjour, bienvenue, buenos dias. I unfortunately cannot speak in Maori or Irish, as we sometimes hear in these webinars. Um, this is the 8th Doctors Say No international webinar. We're an international network of physicians of currently 546 people from 19 countries who have signed on to an open letter stating that euthanasia or assisted suicide are not part of medicine. We write that doctors should be left to focus on advocating for patients, to cure sometimes, to relieve often, and to comfort always. Please encourage your medical colleagues to consider signing this letter. We're privileged to welcome Ramona Coelho and David Shannon. I will tell you more about them in a moment. Those of us who have concerns about the safety of legal euthanasia, which is called medical assistance in dying, or MAiD in Canada, have long suspected that and known that there are instances of death without adequate evaluation, consent, or access to other options, and that the safeguards in the laws do not prevent this. Most data collections don't provide any information on this, but last year, the chief coroner of the Canadian province of Ontario created a committee to examine cases reported that might not have met reasonable and legal standards. Our guests, Ramona and David, are members of that committee, and they will share their personal perspectives on publicly known data from that committee. We're hoping to raise awareness for other countries where the government is considering following the Canadian example. So Ramona Coelho is a dear friend of mine for many years. She's a family physician in London, Ontario. She began her career here in Montreal in home care, where she developed a strong foundation in providing compassionate care to patients who had addictions, complex care needs, or were dying. After moving to London, she established a family practice that primarily serves individuals with disabilities, mental health disorders, and other marginalized groups. She's a well-recognized advocate for vulnerable populations, frequently lending her expertise to legislative discussions and appearing as an expert witness to government committees. She's a recipient of the King Charles III Coronation Medal. She's an adjunct research professor in the Department of Family Medicine at Western University and is a co-editor of the book Unraveling MAiD in Canada, Euthanasia and Assisted Suicide as Medical Care. And recently, I think today, published an article on the World Medical Journal on the same topic that can be found online. David Shannon is a member of the Law Society of Ontario who practices health law in Thunder Bay, Ontario. He received a Master's of Law degree at London School of Economics and has continued his practice and his non-government organization leadership since then. He became the first quadriplegic to trek across Canada in a motorized wheelchair, and later in 2009, he went to the North Pole to celebrate the message that seemingly insurmountable barriers can be overcome. He has received the Order of Canada and the Order of Ontario for his work advancing the rights of disabled persons and other minority groups. He has academic work in the realm of human rights and health law. He's been a sessional lecturer at Lakehead University and Naganuan College, and speaker at numerous conferences across North America. He is also co-editor of another book called Medical Assistance in Dying in Canada, Key Multidisciplinary Perspectives, published by Springer Nature, and the second volume is in development. So Ramona will speak first. Before Ramona speaks, a few words on logistics. They will each speak for about 20 minutes. The chat function is disabled, but as you hear them speak, please write your questions in the Q&A tab. And Dr. Sinead Donnelly and Dr. John Kleinsman, both from New Zealand, will follow the questions and present them to the speakers for the last 20 minutes. Thank you for joining our webinar. We have future ones coming up, and if you have ideas, please share them with us. And particularly, we're interested in webinars in other languages. So go ahead, Ramona.
Thanks, Kathy. Okay. There we go. So Kathy already talked about my book. David has his book. In fact, me and David are writing a chapter for another book that David is writing on medical assistance in dying. We are both members of the Ontario MAiD Death Review Committee, but these presentation is our own opinions, our own personal takes on this. Just for this international audience, I know that this group would know the difference between assisted suicide and euthanasia. In Canada, we call them both MAiD. However, if you look at our statistics, of the 15,000 plus deaths that we have every year, it's been less than a handful, so less than 5 have been assisted suicide. So when we're talking about MAiD in Canada, essentially we're talking about euthanasia. Especially relevant for this group is Drs-say-no, that assisted dying, medical assistance in dying in Canada is not medicine. It was based on court cases that led to legislative changes. It doesn't have its origins in medicine. It was inserted into medicine and can be offered, but it's not left solely to the judgment of the medical practitioner. It's actually prescribed by Canadian legislation. So very different than our evidence-based medicine, which is based on risk to the populations and considering benefits and harms. Medical care, the principles of medical care, which are to target suffering, to have nuanced therapies that are proportional and do not harm the person, are totally incongruent with the philosophy of medical assistance in dying, which aims at ending the sufferer every time, not targeting the suffering. Dr. Harvey Chochinov and Joseph Fiennes have an excellent article in JAMA called "Is Medical Assistance in Dying Part of Palliative Care?" And a lot of their arguments, I encourage you guys who are interested to read the article. It's excellent. And a lot of the issues that they bring about medical assistance not being part of palliative care are exactly why medical assistance in dying is not part of medicine. I have spoken here before in this forum, and I have presented some of these slides, so I'll just quickly review them for those who are new to this. But the initial discourse in Quebec, so me and Kathy are from a province called Quebec. I've now moved to Ontario, but initially when it was presented, it would be an exceptional measure for exceptional cases that Gaetan Barré, who was the politician who brought this in, said, first and foremost, this would be a law of excellent palliative care. We'll get to the coroner report cases and why I don't think that's the case now. And he predicted that there would be 100 requests in the first year. There's an article in the paper where he's surprised because even in the first year, it exceeded what he had expected. Looking at MAiD stats, I mentioned already, and I'm not sure if our sidebar covers the stats, but anyways, we're at over 15,000 deaths per year in 2023. That's our last Health Canada report. However, provincial tallies have come in for 2024, and it looks that we're slightly higher. I think we're still under 16,000, but higher than 2023. So you can see the numbers. Quebec, which had said 100 requests per year, is now having an annual MAiD death rate of over 7%. In fact, they've launched an inquiry. They're doing research as to why that is. Ontario, the province that me and David are in right now, averages about 400 cases a month. The coroner does put out quarterly stats that anyone can access. And you can see that the average time that they quote in terms of connecting to medical assistance and dying services has been, for the last few reports, 2 or 3 days. Shifting language, initially presented as something that would be safeguarded for vulnerable people to avoid wrongful death. Now it's considered barriers to access, and access being the key thing that's promoted in Canada, access to euthanasia. Exceptional measure, that was their very language, is now a response to a need. Selection criteria, similarly, being just called discrimination. You're discriminating against my right to access death. And all based on intolerable suffering, not further defined, not needed to be objectively qualified by the doctor, which is a normal human emotion that we all experience. So just quickly touching before I get on the coroner report cases, some of the concepts that I think that play into showing why there are so many problems with this legislation would be certain biases that physicians and clinicians and our society hold. The first one being ableism. So ableism, like sexism or racism, is a a stereotype that people with disabilities are somehow inferior to people without disabilities, that somehow their way of existing is lesser. And this can be reinforced in unconscious and structural ways that our society develops by lack of accommodation, etc. In terms of in medicine, you can see that there are studies that in the States, I can send anyone, I can send Sinead the studies that we can disseminate, but I'm pretty sure you can access them as well. Many clinicians would guess that the quality of life of people with disabilities is quite low. That would be their clinical assessment, versus most people with disabilities, once their needs are met, rate their quality of life is quite high. So that would be an example for me of ableism, that kind of bias that we carry, that somehow there is suffering and disability, there is a poor quality of life, but actually it's stigma and bias. I'll get to a quote later in this talk, but the president of CAMAP, the current president of CAMAP, did an interview for Associated Press recently, and where she said, MAiD solely for psychosocial suffering such as poverty is forbidden. But a few years ago, she did another interview with a different Canadian journalist, Megan Gilmore, and she's quoted as saying, if I'm going to quote her, I better find that quote. The main cause of suffering is psychosocial poverty, but the person has an irremediable disease, then MAiD is permitted. That's a paraphrase, but that's what she said. And so the conclusion for me is that if someone is poor but not disabled, they can't access MAiD based on that suffering. But if someone is poor and disabled and their poverty is driving their suffering, they can access MAiD. That is an example of an ableist policy in itself, a policy that is discriminating against the lives of people with disabilities. Lots of evidence that we know that people with new illness and injury take time to recover. And in that time to recover, it would be normal to have suicidal ideations, and these should be met with care. They greatly remit over time if people are given a chance, if people's lives are not prematurely ended by MAiD in this time. In terms of the Canadian Association of Suicide Prevention in Canada has released multiple statements. You can look them up on their site. I think they're very good. But they're very concerned about the suicidal messaging that MAiD creates in society, that death can be an answer to life suffering, and the contagion that can create. So we know that, for examples, when Robin Williams committed suicide, that suicide rates temporarily went up in America. We know in Canada, when there is a suicide on an Indigenous reserve, often it leads to a string of suicides. And that is because coping and help seeking versus suicidal and destructive messages, both of them can be contagious. Those messages that we transmit in society are important. And so the actual existence of MAiD can actually affect people's hope, can impact hope. And just very quickly, this statement, you can look it up, but it's written mostly for outside the end of life context. And they have 5 points, but I'll just read quickly that what CASP is saying is that it's imperative that Canadians invest in finding other ways to alleviate suffering, into connecting people to a life worth living. They touch upon the suicidal messaging and contagion. There is a large literature demonstrating that both suicide and coping are contagious. Sending a message that sometimes death is the best remedy for a painful life is likely to subvert suicide prevention messaging, which is one of the few population-level interventions known to decrease suicide rates. And lastly, they talk about a duty to die, or lastly, I'm going to talk about a duty to die. Shifting norms also have the potential to create social pressure or so-called duty to die for people with chronic illnesses who may seek death as a way to alleviate the burden that they perceive are causing others. So if you look at our latest Health Canada reports, for people especially who are dying outside the end-of-life context, but people even in the end-of-life context, there are high rates of loneliness or feeling that you're being a burden as being noted as the suffering that is driving the death request, which I think is quite significant. Our Canadian government has prioritized medical assistance in dying. It's easy to roll out. They've kind of made a promise to make it universally available, and yet there is no such standard for healthcare. We have a socialized healthcare system. And you can see here, as I've just put up, that the wait times for healthcare far exceed the timelines in which you can access MAiD, far exceed the 1 to 2 days that it takes to get in touch with a MAiD provider or MAiD team in Ontario. And there have been cost assessments, which I think bring into question kind of the perverse disincentives when we look at people as expendable, and instead of looking at them as the people that the system is supposed to serve, we can come with all kinds of weird conclusions about what is the best way forward. But it's very important that we realize that that would be basically that we're saying that some people are better off dead and not worth our healthcare system money. Again, just because this is an international group, especially because I know that this is the same kind of, their sister partner groups have started doing this when I was in the UK and Scotland. They were saying that these things are never going to happen. It's like they have the same playbook internationally. So Dying with Dignity still has a page saying, suffering from a lack of social supports does not qualify a person for MAiD. No one can receive MAiD on the basis of inadequate housing, disability supports, or care. However, these people are getting approved on the basis of their disability, but what is driving their suffering is their psychosocial suffering. And here you see a quote from the president of CAMAP saying just that, right? The suffering, that doesn't technically make the cases ineligible. The suffering and remedial disease don't have to be the same. And further, I think since I last presented, this article came out by Weeb and Mullen, no longer denying that these cases are happening, but kind of trying to paint them in like a rosy light, as if that this is a form of harm reduction, that actually letting people end their lives in the context of injustice is harm reduction because you're letting them have choice. But really that begs, like, what kind of choice are we really giving them if we're not willing to help end their poverty, give them community life, help them have resources? That seems to me the poorest kind of offerings of choice. In terms of progression, you see that organ donation in Canada started off as like being uncoupled, or that was the idea that people would not be offered or told about organ donation until they agreed to do MAiD. The newer guidelines suggest to tell people as early as possible to make sure that we get as many organs as possible. Mental illness is already legislated, unless that's stopped, will come into being in 2027. So for the sole reason of mental illness, we'll be able to qualify for MAiD here. We have advanced directives, although they're still criminal under our federal legislation. The province of Quebec has gone forward with advanced requests for advanced directives for MAiD, and our federal government has not challenged them. We have our institutions are under a lot of pressure. I think this had happened already when I spoke to you, but Delta Hospice didn't have a religious creed, but did not want to do MAiD because it's not congruent with the principles of palliative care. They lost their building that they had privately funded. They had funding from the community. They lost their building because they wouldn't do MAiD on its premises. In Quebec, all institutions are meant to do MAiD. It's not clear what the consequences would be if they don't do it, but it's been prescribed that way. And strong lobby groups, they're Dying with Dignity is a group that I mentioned before. There's an article, the lobby group that owns the Conversation on Assisted Dying, and it kind of details the power and the money that this group has. They've started a court case against St. Paul's, which won't do MAiD on its premises, and they talk about forced transfers. In fact, Gabrielle Peters, you can see the article that I highlighted on the side, which she writes in defense of St. Paul's and on MAiD-free spaces and the necessity for disabled people to have MAiD-free spaces. She talks about in that article about how the extreme marketing that Dying with Dignity has, the money that they have, and they actually had marketing meetings and they coined the term forced transfers, because we do transfers for many things all the time, right? Okay. So moving forward, just very quickly, I'm looking at the time. Okay, I have a few minutes. So basically things are not changing in Canada, let's say per se, but there's becoming much more awareness. And I think that that's very helpful for change to happen. You need to have people who are aware. So you had in the past the United Nations representatives concerned, the Human Rights Commissioner of Canada concerned. Emerging, you have many Canadian disability, social justice organizations, etc. And then you have Quebec's End of Life Commission coming out a few years ago, saying that they're noticing some problems with MAiD, that there's a growing non-compliance with procedures, that doctor shopping, for a favorable opinion is not okay, that this is not just a technicality, and that advanced age is not a criterion for MAiD eligibility. Similarly, in our province that David and I are in, the chief coroner is starting to note since 2018 in this memorandum, but been documented many cases of non-compliance with law and policy with MAiD. And so, oh yeah, and then we have investigative reporters at the same time, Maria Cheng and Angie Wang. I forgot to include Angie's name, but there's two reporters for the Associated Press who have access or received access to MAiD provider forms. And in that they detail in their story people who are getting MAiD for poverty, housing insecurity, even obesity. And Alex Rakin talks about this long problem of non-compliance we have that the coroner's actually picked up, and he details that in this article. So our chief coroner put together a MAiD Death Review Committee. We've come out with 2 reports in October and April, and there should be more to come. The first report that came out in October was looking at track 2 deaths. And I will, like, in 2 seconds go over the stats just to show you that people who are not dying have much more residential instability, material deprivation, greater dependency on those. You can see that in terms of what they're offered before death, most of it is drugs. You can see only 50% have, less than 50% have access to disability or mental health supports. Less than 10% had community solutions before they were given death. I think also worrisome is in terms of a next of kin for people outside the end of life context. Many more of them did not have a family member that they could name as their next of kin. They're naming lawyers or doctors, which I think speaks to social isolation. In terms of the report that just came out in April, it was on same day or next day deaths. The day that you request, you get MAiD the same day or the next day. And it was paired with the second, each report had a double report. The second report from April was on our waivers of consent. So this is when you are in the end of life context, you and your MAiD provider agree to that if you lose capacity on the date of provision, you can have MAiD even if you lose capacity. So you could see in the stats that were released on the same day report that there's a huge localization. 51% of all these same day cases are happening in one geographic region, which raises questions about, could this be because they're doing rushed, quick MAiD without really looking at the remediation of suffering, which is, I wrote an article on that you can look up if you want. Okay, I'm going to stop there and just quickly tell you a few cases before I switch hands with David, because I realize I've gone almost over. But in track 2, there's one situation of a man with inflammatory bowel disease. He was sent to a psychiatrist. He had addictions and mental health issues, and the psychiatrist told him about medical assistance in dying. So although he was largely untreated for his mental illness, for his addictions, he was approved for MAiD, and his provider drove him to the location where he had his MAiD provision. In another case, a woman with multiple chemical sensitivities, quite concerned that she would never find a housing situation that suited her, that didn't absolutely isolate her, chose medical assistance in dying and was granted it. A woman in this last report a woman in her 80s, had multiple complications from surgery, so she opted for palliative care at home. Later, there was a MAiD request, but when the MAiD assessor came to the house, she quickly realized that the patient really wanted palliative care, and that was actually her wishes. And so she left. The next day, the husband, having caregiver burnout, tried to take her to the hospital. His wife to the hospital. They sent them home. They tried to access hospital palliative care and were denied based on eligibility. And so the husband called back the care coordination system, and a MAiD provider came to the house, assessed it, said it was urgent. They contacted the first assessor, who questioned this decision about and the urgency, and given her values and preferences that she had just assessed the day before. She asked to come back, but the person who was there denied that, got another MAiD person to come in, who assessed her positively, and they ended her life that day. And a gentleman with Alzheimer's was approved for MAiD with a waiver of consent. His wife mentioned to the MAiD provider, look, I think he's lost capacity. So when the MAiD provider showed up that day and the patient didn't seem to recognize him, he just went ahead and did MAiD. He did not evaluate to even see if he had capacity, if his wishes had changed or not. And the last case before handing over is that a gentleman diagnosed with metastatic cancer. He initially expressed interest in MAiD, but he became delirious. And so his treating team said, well, he's lost capacity. His substitute decision maker agreed for him to be transferred to hospice. But the MAiD provider showed up, withheld meds to try to arouse the patient, documented that through blinks and nods that he thought the patient had capacity. There was a second MAiD assessment that was done virtually, and that patient's life was ended with that kind of assessment. So these are just a few of the cases. I don't have time to go through all of them, but now I hand it over to David.
Ramona, that truly encapsulates some of the realities on the ground. I can share with you almost all of my work in my practice of law is with persons who are legally aided. So in the financial eligibility or financial criteria for that is essentially people in the province of Ontario who are living below the poverty line. As you heard, I practice health law, primarily in the area of mental health. And I will say that medical assistance in dying has certainly entered the lexicon of my client base. I'm hearing it not in the context of mental health and elsewhere. Persons who are in despair, sometimes it's attention seeking, saying, well, I'll just get MAiD. It's normalized. It's in the discourse for persons all over. So this is not an exceptional matter. It's now central in the mediums, and it's rampant. So if Canada might be the canary in the coal mine to have gone from a trickle of 100 or a few hundred just relatively a few years ago to now being over 15,000 and seeing nothing but exponential growth. Have we come from the point of to which it is not just an awareness, but now there's pressure, promotion of MAiD as opposed to a end of life choice. And I will certainly see the note on euphemism and the changed language that Ramona made. I just this morning was reading our one of our national newspapers, the Globe and Mail, and a broad look at the recent legislation passed in the United Kingdom, in which the language is around exceptional cases, end of life, and it was the echoes of exactly what we saw in Canada 8 years ago. And United Kingdom, get ready for the change and the pressures that is not stopping in Canada, and is certainly these pressures around the world will only magnify it appears, not decrease, as Canada remains the canary in the coal mine. Another colleague yesterday texted me, again, only his client base are all legally aided persons living in social despair, and he had to talk to them because they wanted to talk to him about MAiD, and he had to, uh, quite frankly, they just wanted someone to speak to. It's it, it's moving from a medical legal definition to now a normative that is of great concern. And I wanted to say I speak from the perspective, as you heard, I'm a quadriplegic, and yes, I took my wheelchair across Canada in 1997. That's never been repeated, and I've been to the North Pole, and I love adventures, but I also have enjoyed do enjoy my work with the law. It's also very personal to me because of my disability. I'm very aware that, for example, in March of 2017, I had a pressure sore due to a very unexpected, unanticipated small infection that grew very rapidly while I was on March break vacation. This it took me another 21 months before I could receive skin flap surgery for not only the infection but also the tunneling and as a result, I had to spend at least 2/3 or 3/4 of my day in bed, offloading. I was very aware that 21-month wait meant that under the current MAiD regime in Canada, there may have been early on an argument that there would be no waiting period and I would have had MAiD the next day. Or certainly, at the very most, my waiting period for MAiD would have been 90 days, but I could not access health care that would have been life-saving for the next 21 months. So it was quite interesting to try to run a law practice, mostly from laying on my side in bed to then in recovery. I was able to do it, and I'm happy to note that I'm still practicing full time. But it always shocks me how very personal this matter is for me and so many other persons I know with disabilities, that my government has passed legislation to say, yes, your life is not worthy, and you can get MAiD tomorrow, or certainly 90 days maximum, but you can't get a wheelchair, you can't get a walker, you can't find accessible housing, you're going to live in poverty. In other words, all the social determinants of health will impact, and we will not alleviate that suffering. Much of what we've heard from Ramona is so directly on point that we do have ableism in Canada. Access to education greatly reduced and diminished for persons with disabilities. Access to employment greatly reduced. Access to buildings greatly reduced. Of family dissension frequently occurs, and as a result, there is a great deal of discrimination. And I might note that either the Canadian Human Rights Commission or the Ontario Human Rights Commission, when asked for their statistics on the number of human rights complaints made for breaches of the Human Rights Code or Human Rights Act, number one is always disability. And I think that's a good indication of the ableism and how that is also being invoked into the assessment process and the way we treat persons with disabilities at the end of life, especially in the context of medical assistance in dying. I would like to point to the legislation, though, in terms of how we got here. It did begin with a Supreme Court of Canada case in which the Supreme Court, in the Kay Carter case, indicated that there would be no slippery slope in Canada, where certainly that a well-regulated body with oversight of the MAiD regime would certainly find that simply cannot happen. Well, we now have over 15,000, as we've noted, 15,000 MAiD cases in Canada now. And to put that in perspective, where we're approximately 40 million, I think that's a shocking number. But if you may want to look at compare that to the population of the United States, that's as if every single year, 128,000 Americans were to receive euthanasia. That number starts to put it into context in terms of the relative impact on a society, loss of relationships, and the many bereavement issues, in addition to the discrimination issues that are now part of the Canadian reality. So first, there is Bill C-14, and then Bill C-7. In order to be eligible, the person must be receiving government-funded health services, be over the age of 18, although there's new pressures to bring it below 18, as we've heard, have a grievous and irremediable medical condition, have made a voluntary request for MAiD that is not the result of external pressure, and has given informed consent. Now, as you heard from Ramona, there's many cases, however, where there is subtle coercion, forms of pressure. There is the definition of what is grievous and irremediable is ambiguous, broad, vague. It certainly does not pass the test of what we lawyers have to so often frequently deal with, which is very precise definitions and clear language. And unfortunately, there is very little oversight. We are members of the MAiD Death Review Committee in Ontario. That is an advisory body. We only speak from our personal perspective here today, and we'll only do so. But in addition to not having close regulations, we also have then ongoing expansion, and the courts, when asked to provide their oversight, have specifically stated in the province of Nova Scotia, for example, that the courts do not have the institutional capacity to review this, and therefore they refuse to review and just leave it in the hands. And this is quite surprised. I think you'll be surprised to know that the persons who do the report writing, the only meaningful form of oversight is to prepare the reports and provide and note the criteria for MAiD, is the person who actually provided MAiD. So in other words, there is no external objective review. It's certainly a matter of course, the person filling in that report is full of self-interest and would not want to state, yes, I made a mistake. So everything the Supreme Court suggested would not happen, or many of the things suggested by the Supreme Court that would not happen, we see over time have started to creep in, and many of the fears of the advocates who were saying, don't rush into a MAiD regime, and those fears are being realized. I'd also then want to highlight, however, that we speak, well, first of all, you've heard that there is great discussion, debate in Canada that attempts to refute our perspectives that you're hearing today as lone opinions in the minority, fringe, but and we've said no, we're working from evidence-based We know about this. We know about discrimination. We know we know what the future holds. Although it was rejected by both the Supreme Court and many other advocates, such as Dying with Dignity, well-funded advocacy groups. Well, just this past March, the United Nations did reject the Canadian MAiD regime as ableist. This is the body of the CRPD, or in other words, United Nations Convention on the Rights of Persons with Disabilities. They clearly called for a repeal of Track 2, or in other words, if death is not reasonably foreseeable, then MAiD should not be provided. And that means and furthermore, if the sole underlying medical condition is a mental illness, it absolutely should not be provided, and there should be no further expansion, not only to mental illness, but also then to mature minors, and advance requests should be barred. They also noted deep concerns with the Canadian government. They were citing procedural flaws in how the government, both how the legislation was created, and there was a lack of political diligence, a lack of consultation with stakeholders, especially Indigenous groups, and as a result, they had weak legislation that also was based on a lower court decision without the full rigor of what would be not only potentially change healthcare delivery, but have deep social impact on the value of life and how we treat persons with disabilities. The committee noted statistics indicating that Track 2 MAiD was also disproportionately accessed by women with disabilities and persons who are living in marginalized situations, and that the legislation, as I noted, did pass without adequate consultation of Indigenous peoples or sensitivity to Indigenous norms, practices, and traditions. It's also very interesting that, and I believe Ramona outlined this stark choice very well, that MAiD creates a false dichotomy. On one hand, the state, Canada, it perpetuates suffering of persons with disabilities in the ways that I've noted, in particular the intersection of poverty, race, and failed access to health, home care, and disability supports. So they're forced to live a life of marginalization and suffering, but then they're told they can have MAiD immediately, and so they're calling it choice and autonomy, but it's only a masquerade. It's truly a false dichotomy, and it's state-sanctioned suffering, which is so deeply concerning. Ultimately, then, they were defined in their concluding remarks that is not only a faulty premise, but the legislation and its expansion is largely driven by ableism, and that until the government of Canada is able to address the concerns of discrimination and very real marginalization financially and socially, then there will not be an equal, fair, and open choice. In other words, the very liberties, the autonomy that Canada has enshrined in its constitution to be available to every human, and was also part of the argument in the original euthanasia cases, that we, in fact, it must be balanced with equality. If we don't have equality, then we have a false sense of autonomy, and the two must be balanced.
So John and I will just look at the Q&A. John, do you want to start with a question on the Q&A?
So there's a question here from Mark. with respect to the fact that the United Nations has actually directed Canada to suspend its Track 2 MAiD program because of the human rights concerns that you've just been speaking about, David. Mark is wondering whether this has had much impact on Canada, which he notes is a signatory to the UN Charter of Disabilities, and would Canada drop out of the UN over this, the way in which the Canadian Medical Association dropped out of the World Health Organization, essentially because of WHO's opposition to MAiD being unethical?
That's a great question. I don't know. The Canadian government, there's very little comments publicly. Ramona may have heard some more. I tried to track this closely in the media. I saw very little government response to these criticisms. Whether they remain, I hope it truly has the power of moral suasion that before it expands in 2027. That with a new prime minister, a new same party, many new faces in government, that they will have a rethink, and this will be highly influential. And I hope that it also impacts, with our federal system, impacts the delivery of healthcare as delegated authority to the provinces, and they, although not compelled, that they do take note of this being the legal framework that they should follow.
Thanks, David. I just a question to Ramona. Just you mentioned the next of kin data, and that's from just that interesting. So any, I'm not sure other countries collect that data, but could you speak a little bit more about that? You noted in certain areas there was no next of kin except a professional, and that what your observations on that, please.
Yeah, sure. Just before that, just for Mark's question, the Green Party has said that they are interested in taking the UN's recommendations to heart, but obviously they're not the majority of the government. The Conservatives have said that they would repeal MAiD for mental illness, and today they introduced a bill, a private member's bill, though, because they're not the majority to do so. But David, nothing in that UN recommendations is binding, as I understand. So I'm not sure. I think we have to just keep raising public awareness because our politicians are in deep. As for your question about next of kin, I'm not sure if you guys also saw the New York Times story that came out that Mark had commented on in his group emails, where he did a very good synthesis of that article. But a lot of people who are dying under Track 2, so not near the end of life, we've picked up anecdotally from the disability community, they're like emerging stories in the media, are people who are very isolated. And often you see that like they're choosing death because they don't have the support that otherwise they would. And some people have even said that, like Satya Kovac, who died, she lived in I think she lived in Manitoba, had said, it's not that I want to die, it's that the system took me out. Like she wasn't going to be allowed to have home care or have the supports that she needs. And so when the coroner did an analysis, Ontario has more data, I believe, systematically tracked. Not all of it's public, but one of the things that they did release when they were looking at Track 2 people not near the end of life, they looked at their place of residence, whether they were all those different things I talked about. And then one of the things they looked at is if they noted was that they often did not have a next of kin compared to people who in Track 1. So people who were near death were able to list a family member as their next of kin, versus a substantial number, I don't have the report in front of me, but it's online, couldn't name a next of kin, which shows, I think, either the family didn't support their choice of MAiD, that's possible, that why they weren't noted as a next of kin, or they didn't have people in their life, which is why they had to list a lawyer or a doctor. And I take care of very marginalized patients, and sometimes I am their person of contact. Usually those patients are very, very isolated, right, when I am their safety plan. So that's what the report showed, the October one. It's called Report 2024-3.
Thank you.
So there is another question here which just picks up on comments that have been made, and question is about asking for comments from the two of you on what you think might happen with the plan to include mental illness, whether it's likely to be postponed again. I know you've already commented briefly on that, but perhaps you could add to that for our questioner.
Yeah, sure. So I think it's a very good question. When it was again at the 11th hour delayed till 2027, part of the reason it was delayed, the government had kept ignoring the fact that we cannot predict who will not get better. Like, I think this is in terms of like the psychosocial suffering picture, the idea that we can't accurately predict we're going to be ending lives of people who will likely get better. The government was somehow able to resist that, but they found it very compelling that all the provinces, I think 10, David, 10 different provinces, or maybe it was 9 provinces in one jurisdiction, they wrote to the government saying that we don't know how to implement this. We don't even understand how we need time to implement this, or this should be stopped. And so that put a lot of pressure on the government too, the federal government, as the provinces didn't seem like they were willing to roll this out. In fact, Quebec has said they had a commission to study euthanasia, and even though they've gone ahead with advanced requests, they have said thus far that they won't allow MAiD for mental illness. I think Alberta has said the same. And so everything went quiet on MAiD in the media with the election. Things are just emerging now. As I said, Tamara Jansen, a Conservative MP, just introduced a MAiD for mental illness to stop the legislation private members bill today. So I think we'll be understanding in a few weeks better where we land with this new government.
And I could only speak, of course, from a law perspective on this. In addition to the difficulty with the question of whether mental illness is remediable, because of course the legal test is if it's irremediable, then if it's an irremediable condition, then that's one part of the criteria. But certainly in Ontario, under the Mental Health Act, if a person is indicating self-harm, and the self-harm arises from a mental disorder, then they should be in hospital and treated. That's central to the legal test for involuntary status. So if a person has a mental disorder and is indicating self-harm in the context of MAiD, where I would think splicing out the difference between whether MAiD arises in the context of mental illness, the lines are far too blurred. That certainly comes to mind, and I would hope that is part of the province's thinking in realizing it can't be rolled out, because many of these persons it's very important they receive medical care as opposed to the non-medical nature of MAiD.
I mean, we're seeing that already with Track 2, right? We're seeing basically it's up to the provider of whether they think that person's life is worth living or not. And I think whether they're experiencing therapeutic nihilism, like they feel helpless because the patient is helpless, and then they end up helping them end their lives. And I think that what would happen if mental illness went through, you'd have people who were thinking that they're compassionate, but really have just kind of given up on this patient. And it would be very provider and system dependent. That's the other thing that I was pointing out to in the coroner's reports, in the April report. You can even see it for Track 1. There's a huge focus of same-day death, immediate death on request in Western Ontario, which points to that none of these things are standardized. None of these things are evidence-based, and they really run with how the providers practice, which would be very disturbing. To have that other expansion for mental illness.
David, just wanted to check with you. You're very clear. It comes across a very strong voice for people with disability in Ontario and in Canada, and just internationally. What's the strength of that voice for that group of people?
Well, from my perspective, perhaps Ontario in Canada is very much a microcosm of the strength, the strength or lack of strength of that voice. It's very difficult, of course. Disability NGOs or what we call DPOs, disabled persons organizations, frequently underfunded. Many of the persons are, we will have groups from town to town or province to province. So galvanizing both funding and galvanizing support is difficult. It's almost there's many divisions because of the many different needs. And that just then, of course, moves out to international. Although this past week, there's been a meeting in New York of the annual meeting under the Convention of the Rights of Persons with Disabilities. But it is so diffuse that it's very difficult to galvanize.
Thank you. John, there's another question.
Yeah, I just had a question of my own too. And David, just in reference, and this can be for both of you, but David, you made a reference to the fact that it seems that the quality of consent that is being sought from patients, either track 1 or track 2, and also the way in which physicians are approaching the quality or measuring coercion differs from the standards within legal practice, so that there has been, I'll use the word slippage. Do you want to say just a little bit more about that? And perhaps Ramona, you have some comments about that as well.
I am not an expert in the tool, of course, but my work for the past 30 years has very much been in the area of consent and capacity, and that's a very rigorous legal definition. And usually, I'm on the patient side, the patients who don't want to take their medicine, and it's a very rigorous legal test, where I'm before review boards frequently on that very question. So when I've seen that slippage you've spoken of with respect to distress, where persons are clearly distressed, their decision making is compromised. There's a question of what certainly they might understand the information handed, but not appreciate the consequences of their decisions, and that's simply. It's been my observation anyway that it's not received a rigorous oversight of any sort in the context of MAiD, whereas in the area of the Mental Health Act, or I should say Healthcare Consent Act, in the context of psychiatric care, it has received that greater rigor. So it's been, from my perspective, my professional perspective, it's been quite shocking, quite honestly.
It looks like our time is just about up. This certainly touches us as physicians, because we see people in these situations of despair, of not having access to the resources they need, and we see how easily they can turn towards requests for death. We've seen families that are torn apart when one person can't handle the suffering of the sick person and cannot imagine any other outcome. So thank you both for sharing your knowledge, your expertise, your experience in this area. The webinar will be posted online shortly, and so hopefully beyond those who heard it today, many more people will be able to listen to you. Thanks for your time, and thanks to everyone who listened.
I want to thank everyone who got up at 7 a.m. today.
Before 7 a.m.
Yeah.